Thank you so much for joining me to learn more about our recent article in the British Medical Journal. Before I begin, I just want to be transparent about the fact that we tested an intervention that we ultimately have spun off into a company called Health Outcomes Sciences to try and support, disseminate, and improve this intervention over time. And what we were trying to do in this study was to try and improve the value of healthcare, particularly in angioplasty, by improving patients' experiences with care, by improving the outcomes, all while lowering costs. And in particular, we wanted to address the challenge that care needs to be provided in a very reproducible fashion, which is something we learned from this study. We focused on trying to reduce bleeding at the time of angioplasty, which is the second most common non-cardiac complication and is associated with lots of morbidity and expense when it occurs. And the American College of Cardiology and American Heart Association guidelines even recommend that we risk stratify patients for bleeding because there are treatments like radial approaches and bivalirudin that can reduce bleeding when applied to high-risk patients. And yet, in 1.5 million patients in the United States in the NCDR registry, we found that bivalirudin, a very expensive alternative to heparin, but that one that does reduce the risk of bleeding, was preferentially applied in the lowest risk patients who benefit least, and least often applied in the highest risk patients who benefit most. And so we would like to see a reduction in bivalirudin in the low risk patients and an increase in the moderate and high risk patients. So we worked with the NCDR to build a model to predict bleeding rates. And this model can be calculated for each and every patient to estimate their particular rate of bleeding. And yet these models are very hard to integrate in routine clinical care. There have been web-based tools forever that have not been used in routine clinical practice very efficiently. So we sought to replace the consent forms, which every patient needs to complete before they undergo angioplasty, and which currently does not inform or educate patients much, with a personalized consent form that provides much greater explanation for what an angiogram, angioplasty, and a stent are, but also that embedded each patient's predicted risk of bleeding from the actual NCDR risk model. And we implemented this at 9 US sites and were able to compare the change in bleeding and the change in bivalirudin use before and after implementing the personalized consent forms at these 9 sites, and to compare it with 1,100 other sites in the rest of the country. And this slide shows that the bleeding risk is on the x-axis, the observed bleeding is on the y-axis, that before the doctors knew the risk of their patients for bleeding, there was a significant increase in bleeding rates as the bleeding risk went up. But that after the doctors knew, there was a significant decrease in bleeding, particularly in the high-risk patients, which is where you would expect it. And this agreed with a significant increase in the use of bivalirudin in the high-risk patients, or any bleeding avoidance strategy in high-risk patients, and less use in the low-risk patients. In a fully adjusted model, we found that there was a 44% reduction in the risk of bleeding at our 9 centers. Across the rest of the country, there was a 13% reduction in bleeding, which was about a third of what we observed in our 9 centers. So collectively, we also found a very important challenge that we didn't anticipate in this study, which is the marked variability across doctors. And this shows both before and after PRISM a remarkable difference in the way that individual doctors treat patients according to their bleeding risk. Although it is better afterwards, there's still a lot of variability, and that will warrant future investigation in the use of protocols and incentives to get physicians to pay attention to the patient's bleeding risks. So in summary, we think that this kind of personalized consent can improve patients' experiences, and in February of this year, the American Heart Journal shared our results from this trial from the patient's perspective. But this study showed that we were able to improve tailoring treatment to risk and significantly reduce bleeding while also reducing costs. Thank you very much for allowing us to share our findings with you, and if you have any additional questions, please email me. Thank you very much.